This is Emergency Medicine Cases EM Quick Hits podcast, and I'm your host, Dr. Anton Hellman.
EM Cases is brought to you by SHREMI, the Schwartz-Reisman Emergency Medicine Institute. That's a nonprofit organization dedicated to improving EM care through high-quality research and education. The opinions expressed on this podcast are intended for general information and educational purposes only and should not be used to diagnose, treat, or prevent any medical condition, nor should they be used as a substitute for medical advice from a qualified practicing physician. Unless stated otherwise, the opinions expressed by the hosts or guests are made in their individual capacity, not on behalf of the Institute nor Medicine Cases. First, a word from our sponsor, Metricade, the experts in complex physician scheduling since 2012. I've been using Metricade's incredible scheduling system for a decade, and it's been a game changer for me and my colleagues. Shift work comes with its challenges, but Metricade helps minimize the drawbacks by ensuring a fair distribution of shifts while integrating circadian-friendly rhythm recovery time into its methodology. Less sleep deprivation means I can be a better EM doc on shift and still have energy for life outside the hospital. Check out metricade.com/EM cases to make your schedule fair and improve your sleep. This episode is brought to you by Paratus, your ultimate assistant for every emergency. Built on the trusted foundation of Easy Resus, Paratus brings you intelligent search, a complete library of procedures and protocols, and Atoms, your assistant to obtain the right information when seconds count. Discover Paratus today at paratusmedical.com/EM cases and be ready for anything. All right, this is a special installment in a newer EM Quick Hits series we're calling Medmal Cases. Now, these are going to be real medical malpractice cases, fully adjudicated, cases that closed a long time ago and so are part of the public record. We're not here to judge or to assign blame. We're here to learn, because buried inside these cases are some really powerful lessons in emergency medicine. And joining me today is Dr. Mike Weinstock. He's an emergency physician, adjunct professor at Ohio State, research director at ADINA, co-host of MRAP's UC Max, educator, and author of the terrific Bounce Backs series of books, which many of you already know as pretty much required reading for avoiding diagnostic disaster in the ED. Mike, thanks so much for joining us.
Thank you so much for having me. It's an honor to be here.
Fantastic. So as we go through this case, I'd like you to feel like you're kind of standing there in the ED, seeing this patient in real time. I'll reveal the case sort of one piece at a time, and after each piece, Mike's going to walk us through what he's thinking, and then you should be thinking what you should do as well. So let's just dive in. It's a Sunday afternoon in April, and a 42-year-old man presents to an urgent care clinic with the chief complaint of upper back pain. He describes heartburn, regurgitation, upper back pain, and generalized body aches. He rates his pain as 4 out of 10, and he tells you that it's worse at night. In terms of pertinent negatives, he denies fever, he denies chest pain, he denies shortness of breath, he denies any numbness, tingling, or weakness, he denies any bowel or bladder issues. On exam, his vitals are normal, he's afebrile. Let's just stop here. And I want you to ask yourself here, what's your differential so far? Ask yourself, does upper back pain belong in the same mental bucket as low back pain? And if there was a single test or question that you wanted to get, what would that be that would help change your management plan for this patient? But let's ask Mike. Mike, what are your kind of general thoughts on the case so far?
Well, this case really speaks to some of the primary type of teaching points that I've been really talking about through my whole career. And I'm going to start with the last thing that you said, this one question. I call it the game-changing question. And it could be as simple for a patient in a motor vehicle accident, right? Are you on anticoagulants? Because we know from a study by Nishijima, as well as other studies, that even if the patient doesn't have loss of consciousness, if there's no visible signs of head trauma, they still could have a bleed. So not aspirin, but if you're on clopidogrel, one of the DOACs or warfarin, you still need to do that head CT, right? That's the game-changing question that could change the trajectory of the case. And in the same way, when we look at the history here, what I see in this patient with upper back pain is really just a restatement of the chief complaint. I ask myself, and a lot of the residency lectures that I do around the country, I start these lectures by saying, how lucky do you feel? Because in the end, most of the time, even with chest pain, and I know this patient had back pain, most of the time with chest pain, it's going to be benign. So based on a study by Farinoff, ACS in all of our ED chest pain patients, ACS is present about 1 out of 10, might be 1 out of 20, but just to keep a round number, let's say 1 out of 10. Pulmonary embolism, 1 out of 100. And based on a study by Alter, aortic dissection is about 1 in 1,000. So in the end, if you're not even thinking about aortic dissection or asking any question to it, you're still 99.9% right. Patients you don't even evaluate. But in the end, how lucky do you feel, right? How lucky do you hope to be with the average patient that comes in if you don't even gather adequate data? Because if you don't gather that data, how do you know what to do? And that's what I see with this case specifically. This patient had upper back pain. We don't know the acuity of the onset. We don't know what makes it better or makes it worse. Is it worse with twisting or is it worse with exertion? So when you think about the questions you'd want to ask for upper back pain, well, the onset, right? Did it start when you're lifting a dresser? Or did it start more gradually while you're walking up the stairs? And speaking of that, is it something that's exertional? Because really your thorax is part of your chest, right? Could this be something like ACS? Is it pleuritic pain? Could that be a pulmonary embolism? And are there other associated symptoms such as dyspnea on exertion, hemoptysis, unilateral pain or swelling of the lower extremities or any extremity really? Or even when you think about something like dissection, did it start suddenly? Is it pain out of proportion? What's the character of the discomfort? Is it ripping and tearing, for example? None of those questions were asked in this situation.
Yeah, it really does all come down to the HPI and a really thorough HPI. It's these simple questions that really we just learned in medical school that need to not only be asked, but documented as well.
Well, speaking of documentation, when you think about standard of care or excellence in care, and again, not necessarily medical legal, but maybe more so patient safety focused, right? And I'm just going to give another example. So say, for example, on your right lower leg, on the medial aspect, there's a 4 by 6 centimeter area of erythema and warmth. That's good, right? It's a good description of what sounds like cellulitis. But what's better is to then extend it, say all of that, plus, and there's no crepitus, necrosis, fluctuance, ecchymosis, bulla, right? And so now what you're saying is you think it is cellulitis, and you've considered, and you don't think it's a necrotizing soft tissue infection like neck fash or a deep space abscess or another more serious problem named compartment syndrome. Something would be less likely, of course. But in the end, that documentation and that data gathering of sudden is good. And I think that's good. And I think maybe that's standard of care. But what's better, when did the discomfort start and when did it reach maximum intensity? So for example, with something like subarachnoid hemorrhage, right? The patient said it started suddenly, and then I say, when did it start and when was it at its worst? They say, well, it started at noon, and by 4 p.m, it was severe. Well, to you and me, who've been practicing medicine for decades, that's a gradual onset to us. But for the patient, in the context of their life, that might have been a sudden onset. The more specific documentation wins.
Absolutely. So let's talk about what was documented in this case. So for the past medical history, it was documented that the patient suffered from insomnia and GERD, that the patient was recently treated for H. pylori. The social history was documented as no tobacco smoking, no alcohol, no recreational drugs, and the review of systems was largely negative. For the physical exam, they documented basically normal heart and lung exam and normal neurologic exam. There was no back exam documented, no spine palpitation, no range of motion. And then the discharge diagnosis was threefold: myalgias, muscle spasm, and GERD. And the patient was discharged on lansoprazole, a PPI, and cyclobenzaprine. So here, for the listeners, I want you to ask yourself, what specific historical features would lower your concern for a dangerous cause? Like, what pertinent negatives do you want to kind of get out of there? And what risk factors do you want to ask about in this patient? Because there wasn't much in terms of risk factors for cardiovascular disease, for dissection, for pulmonary embolism, which for me, anyone that comes in with an unusual pain anywhere above the waist, I'm going to be asking about all those risk factors. So Mike, for you, what's missing here?
Well, this is a classic case of what Pat Crosscarry has described as diagnosis momentum, where we think about a previous diagnosis, and in the end, if this is H. pylori, GERD, esophagitis, gastritis, peptic ulcer disease, But in the end, there really wasn't anything supporting that in the data gathering that they did, either in the history or on the exam. And I get it that you don't really have an exam that's going to specifically tell you about GERD. However, this is a huge failing with mostly patient safety and misdiagnosis, is when the question that's asked in the chief complaint doesn't go along with the diagnosis. So when you think about this patient, they had upper back pain, and in the end, the diagnosis was myalgias, muscle spasm, and then GERD. And there really wasn't anything at all in this history of present illness of GERD. In fact, they say here, chief complaint upper back pain, the HPI is, he describes, and this is the actual documentation on the chart. Okay, so it's not like we made this up in any way, shape, or form. He describes heartburn. Well, what does that even mean, right? He describes heartburn. Tell us what that means. What does he actually describe? And I sort of make this joke. I mean, maybe it's a little, mean-spirited, I guess, in some ways. But, the patient says, I have a migraine. And then I say in sort of a funny way, or I think in a funny way, to the patient, no, you have a headache. I'll tell you if it's a migraine, right? The patient said, I've got kidney pain. I say, no, you have flank pain. I'll tell you if it's kidney pain. And in that same way, this patient said they have heartburn. Well, heartburn certainly could be ACS. It could be 1,000 other things also, or it could be from reflux, right? But they didn't have a history of present illness on here. That was the argument. And I talk about this very, very frequently, is that our chart is an argument. It's a story that has to have a logical beginning, middle, and end, and it has to be an argument for what we come up with as our diagnosis. And in this case, there was a chief complaint. The diagnosis is different than the chief complaint, and it doesn't follow in a logical fashion. And unfortunately, what we're going to find out with some of these cases, and again, you can get lucky, right? You can get lucky because most of our patients, even in the ED, 80% of them get discharged home, right? So you can get lucky, but not through the course of a career, not for 150 to 200,000 patients you'll see during the course of a 30 or 40-year career. You can't get lucky for that long on all of those patients.
Totally. Let's move on with the story now. So it's 2 hours later, and EMS brings in the patient to the ED, and this time it's in cardiac arrest. So he had a witness collapse. His initial rhythm was ventricular tachycardia. He had multiple shocks, epinephrine, amiodarone, all given in the field. There was no meaningful history available to EMS. And at this point, I'm sure there's lots of questions going through our listeners' minds and Mike's as well. Probably some of you are asking yourselves, what's the differential diagnosis now of this arrest? If standard defibrillation fails, what options do you have now? What's going to be your next move? Let's kind of break those down one at a time. So as the EM doc on duty, and you're the team leader, Mike, what's running through your head right now in terms of the differential and your next move?
Well, if we did have the information that 2 hours earlier, the patient was seen with back pain and sent home, all of a sudden we're able to really narrow things down. But as far as the differential, I usually think in a patient that has back pain or back and chest pain of those, what we call the big three, right? ACS, PE, and dissection. And in this situation, if it's dissection and the patient's in arrest, you're probably not going to be able to resuscitate him. If it's a pulmonary embolism, maybe some sort of saddle embolus, there is some fairly, okay data that we can give systemic thrombolytics even in arrest. And I've had several patients where I've done this and I've got them back to hospital discharge. However, it's rare, especially if they come in with this type of arrest. Now, his was witnessed, so that's a good thing. If it's ACS, in that same way, we want to make sure that we do all of the things we typically do with ACLS, right? And epinephrine and shocks and, bagging and good quality compressions, right? But in the end, until we get that patient back and we get a rhythm and we're able to get an ECG to see if there's a STEMI at that time, if we aren't even able to get that point, our prognosis is going to be extremely, extremely poor.
Absolutely. So in terms of your next move, he's had a couple of rounds of epinephrine. He's had 3 rounds of defibrillation. What are you going to do next?
So as far as working through that ACLS algorithm, well, if we still don't have anything, certainly we can try the dual sequence defibrillation if he's in a shockable rhythm, of course, right? we can certainly think about things like, Esmol, if he's had multiple rounds of epinephrine from the paramedics, we could try that sort of thing. These are last-ditch efforts. And in the end, we want to think about things that could be reversible. And at this point, there's probably not tons more things that are reversible beyond what we're already doing. There's not great reason to think that this is a pulmonary embolism. If it's a dissection, we're not going to get him back. I mean, to me, it feels like at his age and with the back pain, ACS is probably the most likely consideration. But at this point, we just need to do all of our standard stuff. Now, recent data giving calcium isn't helpful. Sodium bicarb, I guess you could try it, but probably it's not going to be helpful. And again, if you've done multiple rounds of epinephrine, you could try the esmolol stuff, but it's probably not going to be helpful in this situation.
Yeah, I agree. At this point, unfortunately, the physicians who are resuscitating him now from cardiac arrest don't have the history that he was seen at the urgent care with back pain. I think the big question in my mind next would be, should I thrombolize this patient or not?
You would think that, this guy's 42, but say he was 82. Most people, when they go arrest, it's from an MI, right? So you'd think that thrombolytics during arrest potentially could be helpful. But the data is pretty clear that they're not helpful. In the end, the other thought is, if we do get ROSC, if we don't see a STEMI on the EKG, well, hey, maybe it's still helpful to do a cath to see if that would make a difference. Well, based on a study by Lemke, another study by Deutsch, both of these are randomized multi-center studies, and they haven't shown an advantage with any of their either primary or secondary endpoints unless you have a STEMI on that post-ROSC ECG.
So yeah, the question of whether to send the patient straight to the cath lab or not if you do get ROSC, we're going to address in a minute.
Okay.
Let's go on with the story here. So after a prolonged resuscitation with smooth endotracheal intubation, a few rounds of epi, and 3 rounds of defibrillation, ROSC is achieved. His vitals now, after ROSC, are a blood pressure of 86/49. He's bradycardic at 38 beats per minute, and he's severely acidotic with a pH of 7.08. You get a quick ECG, and it shows ST depression. There's no STEMI. A quick POCUS is done, and it shows obvious global hypokinesis. Cardiology is consulted, but the cath lab is not immediately activated. Then the patient's family arrives, and at that point, they tell the physician that he's had heartburn and back pain for 2 days, and that he was discharged from the urgent care center earlier that day. So, Mike, now let's talk about that cath lab activation. With this story and that ECG, would you consider activating the cath lab? And I guess the second question there is the bradycardia of 38. How would you manage that?
So as far as the cath lab, you would think that it's a good idea, right? Because most patients that have arrests maybe are having arrests from MI, from ischemia. However, there's 2 studies that I wanted to focus on. One is a 2019 New England Journal of Medicine study by Lemke et al., where they looked at 552 post-arrest patients without a STEMI, and they randomized them to either get immediate angiography versus delayed angiography. And none of the primary outcomes or secondary outcomes, and they looked at everything, such as survival to hospital discharge or time in the ICU, duration of mechanical ventilation, neurologic status, all those things. None of those were different with immediate versus delayed angiography. And there was another subsequent study by Desch looked at almost an identical number of patients, and that study was done in 2021, so still pretty recent, found really identical findings. So no, if you don't have a STEMI, it can make it really easy. Do not need to activate the cath lab.
Just to clarify the nuances here, based on the 2025 AHA guidelines and some more recent studies, you still want to consider activating the cath lab, or at least speak to your interventional cardiologists for a list of high-risk phenotypes. And they are the following. As we said, persistent ST segment elevation or STEMI equivalent on a post-ROSC ECG, Number 2, cardiogenic shock or severe hemodynamic instability presumed due to acute coronary occlusion. Number 3, recurrent ventricular arrhythmias, so recurrent VT or VF or electrical storm after ROSC, especially with suspected ischemic cause. And finally, evidence of significant ongoing myocardial ischemia despite ROSC and no clear ST elevation. So dynamic ST changes, marked diffuse ST depression, ischemic symptoms if they're awake, or clear biomarker or imaging evidence of active ischemia. So while the evidence is really only good for ST elevation for the cath lab, there are a list of other criteria where cath lab should be considered, and that should be a call to your interventional cardiologist. All right, let's talk a little bit from a medical legal standpoint, what could have changed the outcome. So do you think if this patient was recognized earlier, do you think it would have actually changed the outcome?
Short answer is yes. And when I think of all the things we do in medicine, right? Antibiotics for sinusitis, which usually viral, probably number needed to treat very, very high, but potentially could be helpful. Not that I do it very commonly. Or, for example, antihypertensive therapy, obviously a good idea, but still, it's not like every single patient you treat, you're going to prolong their life. Well, when you think of a patient who has a coronary occlusion, and if it's okay, I'll give the end of this case is that when he did have cardiac cath, he had 100% LAD occlusion. And so now looking back on it, we can say to ourselves, of course, the fact that he had this back pain 2 hours earlier was from his occlusion. And if we had got him to cath lab earlier, for example, an ECG had been done, for example, even tracing it back further, because we ask about the back pain, and it was exertional. There was associated diaphoresis and dyspnea. It did have some radiation, maybe to the jaw, just for example. There wasn't an alternative explanation. And you highlighted a few minutes ago, very appropriately, that, come on, folks, he has back pain and they didn't even examine the back. Think of other times. There's a lot of cases where a patient has a neuro complaint that could be dizziness or confusion or even weakness, tiredness, incontinence, numbness, right? Where there's only the most cursory of neuro exams done. And in the same situation, if we push on this patient's back, we have him rotate side to side, and we ask about, for example, the onset, and he doesn't say it started suddenly when I was lifting a dresser, well, now what we have is no other great explanation mechanically in the back, and we have to start looking for other possible reasons. We have to expand our differential, and one of the things that we're going to expand our differential to is ACS. So this is what we call in America loss of chance, and the loss of chance is the loss of the opportunity to get better based on a proven intervention. And of all the interventions that we have, a cardiac catheterization, that is something that definitively has been proven successful and definitively decreases mortality.
Absolutely. Let's give the listeners the outcome. So as you mentioned, he did eventually have a cardiac cath, and it showed a 100% occlusion of the proximal LAD. He had a drug-eluting stent placed, but unfortunately, he sustained severe anoxic brain injury. He never regained consciousness, and he was terminally extubated several days later. So, Mike, what are the key lessons here for emergency physicians from a clinical point of view, from a medical legal point of view? What do you want the listeners to go home with for their next shift?
So we have three real big take-home points. And the first one is that upper back pain is a high-risk complaint in a similar way as to chest pain, especially in a patient where it's not worse with range of motion or palpation. So if we ask ourselves one simple question, the patient bounces back, whether it's in 2 hours or 2 days, horizontal and room temperature, in other words, dead or in arrest, right? What could I have missed? And then before the patient leaves the ED or the urgent care in this specific situation, then ask questions as to those potentially concerning diagnoses. So what's on the differential for upper back pain? Well, certainly simple things like a muscular strain or zoster. We also have more concerning things like, for example, a spinal epidural abscess. We have other things because it is part of the chest, like acute coronary syndrome, certainly a PE, or a thoracic aortic dissection. Sudden onset, ripping and tearing, severe pain, pain out of proportion, those above and below diaphragm symptoms, lack of a viable alternative reason for that. Secondly, we have to be very cautious about allowing a patient to give us the diagnosis. This patient said he had heartburn. He was convinced this was from reflux. Well, if he was really that convinced, he wouldn't be seeing us in an urgent care or an emergency department. And in the end, there had to be some question in his mind. So it's incumbent upon us to gather additional history as to the character of the symptoms, the acuity of the onset, the exacerbated and relieving symptoms, radiation, all those other things we ask with that old CARS mnemonic, onset, location, duration, et cetera, that a lot of us ask. And then the third point, and I really want it to be clear here because, look, I'm in America. I get it. There's a lot of medical legal things happening here, more so than other places. But in the end, I'll leave this with the statement that I end a lot of my lectures with, is that we shouldn't be practicing defensive medicine, but evaluating and documenting in a way that is defensible.
Great. I wanted to go back to your first point that you made there. The simultaneous symptom of heartburn and back pain, those really should raise alarms. I mean, I personally suffer from GERD myself, and I can tell you that GERD does not cause back pain.
Right, exactly.
An ulcer that's eaten through the posterior stomach wall and bled out can cause back pain, but GERD and back pain just don't go together in the first place. So I think that should be kind of part of the take-home point there. And of course, we all learned in medical school that anyone who says the word heartburn in the emergency department is an MI until proven otherwise.
Yeah, and we've all had stories, and I'm sure you've had this exact same thing when the patient says, no, I don't have chest pain. You're walking out of the room and they say, but how about this elephant sitting on my chest? I ask any chest pain or tightness or pressure or discomfort. And to me, that feels like that gives the patient the opportunity to say that it just doesn't feel right. And it doesn't really differentiate to an adequate way, whether it's pressure or tightness. None of those things can tell us for sure one way or the other. Heartburn, man, that is the thing that will get you every time. And I'm always super cautious of that, just like it sounds like you are.
Great. Well, thanks so much, Mike. Those are some great take-home points. I hope our listeners got some practical learning pearls from that. And to start thinking a little bit about the medical legal aspects of cases, which we've never really talked about in depth before on EM cases. So thanks so much.
Thanks again for having me.
Next up, we have our go-to trauma expert, Dr. Andrew Petrosoniak, who's going to talk about chest tubes for traumatic pneumothorax and hemothorax.
I just realized we haven't discussed traumatic pneumothoraces or hemothoraces, so let's get into it. When I started on this topic, I thought I could do it in a single go, but I got a little bit carried away, so I've recorded it in two parts. The first part covers who needs a chest tube and an imaging discussion around the types of modalities, CT, ultrasound, and X-ray. And part two focuses on types of chest tubes and some tricks and tips for insertion. But we're going to get started using a case to guide the discussion. So you're working in the ED. EMS brings in a 43-year-old male involved in a high-speed MVC. He had transient hypotension, 84 on 51, that's now improved spontaneously to 105 on 60, but still requiring some O2. Initially, O2 saturations with EMS were 85%, but improved to 99% on a non-rebreather. He's GCS 15, he has an obvious seatbelt sign across his chest. There's no palpable subcutaneous emphysema, but he remains tachycardic at 110. His rest rate is 30. And of note, he has no underlying medical condition. It seems pretty clear that he has chest trauma, and that's going to be the focus of both this quick hit and the next one. Does he have a pneumo? Does he have a hemo? And if so, how should we diagnose and manage it? So the first thing I do when I see these patients with suspected chest trauma is I'll break it down into three categories in my mind. Number one, peri-arrest patient. That's the patient that is going or imminently seeming like they're going to die. Number two is the hemodynamically unstable patient. That's the patient that might have hypotension, might be fairly hypoxic, but I have a few minutes to organize myself. And then I think within two, there's a second part. There's the precariously stable patient, and that's the patient that seems a little bit more stable, maybe just a couple of liters of O2, maybe a few drops in the BP, but not quite as unstable as what we truly understand to be hemodynamically unstable. And then number 3, the completely stable patient, or patient that's really not requiring any interventions, has a normal blood pressure and normal O2 saturations. So how does the management and approach for each of these differ? Well, let's start with the peri-arrest scenario. And I'm going to leave any mention of tamponade and cardiac injury out of this for simplicity, other than to say my first move with ultrasound when these patients roll in is a cardiac view, usually a subcostal view, to look for tamponade. But let's assume there's no evidence of that, no evidence of cardiac injury, and we'll focus on the lungs. So I'll try and evaluate the lungs for lung slide. And sometimes either I can't get a great view due to subcutaneous emphysema, or there's simply no time. So if I can establish a pneumo on ultrasound, then I'll go ahead and do a finger thoracostomy on that side. But sometimes these patients that are peri-arrest, there's really no time, and I'll actually just go ahead and decompress both sides of the chest. And what we're doing here is basically the first part of the chest tube. That's kind of part 1. Getting into the chest, and part 2, putting in the chest tube. Except we omit the chest tube placement piece temporarily, at least up front. And I try and do these sterile, but sometimes it ends up more being just a clean procedure. I landmark, I prep with betadine, and then I make an incision followed by blunt dissection with Kelly's and enter into the thoracic cavity to relieve the tension. And it's no problems to hold off for a few minutes putting in the tube and come back to it and place it later, especially if you're in a one doc ED where you then have to go manage the airway. And really the only time I deviate from that is, if there's a bunch of blood pouring out, sometimes it's best just to have a tube go in so that we can drain the blood appropriately. And the goal is rapid decompression, and honestly, this should happen within 30 seconds on each side. So once the patient is stabilized and the airway is managed along with other priorities, go ahead and place the chest tube. In some instances, I decompress the chest first to optimize intubation hemodynamics, but these two procedures can occur nearly simultaneously. If I had to choose, I typically like to decompress the chest first to improve hypoxia, reduce risk of hypotension, or improve any obstructive shock. But I'm really not worried that intubation before decompression will worsen a tension phenomena, as long as I'm prepping to intubate and to decompress within a few minutes. The bigger issue really is that intubating a patient who is hypoxic or hypotensive can be quite a big risk. All right, so this patient falls more under the second category, the hemodynamically unstable, or maybe unstable-ish, or precariously unstable, depending on how you want to think about it. He has new O2 requirements, and there's a few things here. I never auscultate the lungs in these patients. I think it's a big waste of time. It's not reliable. You have a better tool, the ultrasound, and a portable chest x-ray. Another exam pearl is that you'll probably never see tracheal deviation. I don't even bother looking for it. The key information for me is there hypotension? Is there hypoxia? And is there evidence of pneumothorax on ultrasound or chest x-ray? So my first move in this patient is to evaluate with an ultrasound and examine for subcutaneous emphysema. Once I see absent lung slide, and I always recommend comparing it to the other side, I know they'll need a chest tube. He's on O2. He's going to need a chest tube inserted. If it's feasible, and it often is, I'll also get a chest x-ray before proceeding. Usually the chest x-ray is done supine, and it's not uncommon for it to appear normal and still have a pneumothorax. The ultrasound has a high sensitivity of about over 90%. Chest x-rays, especially supine ones, are far less sensitive, quoted around 50%. One thing to look for, as it's far less common to see separation of the lung and chest wall, is to look for a deep sulcus sign, which is basically an air bubble that accumulates in the costal margin. As a mental model, I consider these patients as having tension phenomena when they have hemodynamic compromise. While hypoxia alone isn't quite tension, I still categorize them as similar in that they need fairly urgent chest tube insertion. The question is whether to put the chest tube in immediately in the recess room or go to CT. And this is a gray zone and is probably center and patient dependent. Sometimes if the patient is only on nasal prongs less than a few liters without increased work of breathing, I wait. But for me, if They're on a non-rebreather, significant increased work of breathing. I just go ahead and place the chest tube before CT based on the hypoxia, the absent lung slide, and the findings on chest x-ray. Logistically, I just find it easier. But I think if the chest x-ray is normal, there's no signs of contusion or rib fractures, and you're uncertain about your ultrasound findings, then it's reasonable to wait. The other thing I'll often do is scan down to look for fluid or blood in the chest, though using ultrasound, it can be difficult to approximate volume. But if there's no pneumo and only a possible hemo, I usually go to CT. Now, finally, let's talk about the stable patient. That's the patient that is hemodynamically stable, not requiring O2. And for the patient who identify absent lung slide, but on room air and normotensive, I definitely will get a chest x-ray. But I'll be honest, my default is often to get a CT. It just allows for easier decision-making and understand truly what's happening in the chest. Now let's briefly talk a bit about what we should be looking for on x-ray and CT. There's a couple measurements that can help you. With chest x-ray, the literature suggests the distance from the lung to the chest wall, if it's greater than 38 millimeters or 20% of the lung field, then the patient needs to have a chest tube inserted. Similarly, on chest CT, 35 millimeters on axial view, and you find the largest distance between the lung and the chest wall. So if it's greater than 35 millimeters, and this really only applies if there's no concomitant hemothorax and the patient's not requiring O2 and is hypotensive, but just a finding of 35 millimeters or greater, then go ahead and put in a chest tube. And then when we're looking at hemothorax, really we need a CT to evaluate the size of the hemo. And it can be difficult to measure. There is a formula, but I've really never used it. I often ask my radiologist, is there a hemo greater than about 300 milliliters? And that's really the cutoff that's found in the literature. And the formula, which you can look up, is Murgo's formula, but it's a little bit complex. And practically, I just look for a hemothorax on CT with a thickness greater than 1.5 centimeters. Or more realistically, I just kind of look at the CT and see, do I think a chest tube is actually going to fit in there and allow for appropriate drainage? On a chest x-ray, it's a bit harder to quantify, and I often like to get a CT in the stable patient before proceeding with the chest tube. But remember, all of these are just approximates, and it really depends on the patient clinically, how hypoxic, their work of breathing, and if there's any clinical confounders, these also need to be considered. Okay, so that's it for this section. We'll be back to talk about the types of tubes and a few other pearls a bit later.
And now a quick word from one of our sponsors. Are you an ER doc looking for an exciting opportunity? Cornwall Community Hospital is hiring motivated ER docs to join their dynamic team. With over 50,000 visits a year, you'll see a wide variety of pathologies in a fast-paced, supportive environment. Your colleagues and consultants are always ready and willing to back you up. Cornwall, Ontario is a hidden gem on the St. Lawrence River, offering waterfront access, outdoor activities, and a small city charm, all within an hour's drive from Ottawa and Montreal. Join the family at Cornwall Community Hospital, and once you're there, you'll never look back. For more information, please visit www.cornwallhospital.ca and click on Join Our Team, Physician Recruitment, or call 613-938-4240, extension 227.
What if I told you you could avoid that phone call to neurosurgery? You know the one. It doesn't seem necessary. It's a tiny bleed. You know it's not neurosurgical. You know that the plan is just going to be observation and a repeat CT scan. But because of hospital politics, you're forced to call the neurosurgeon anyway. What if I told you you could stop making those calls? Would that make you love evidence-based medicine? Let's talk about the brain injury guidelines. And before I alienate any wonderful clinicians out there, let me just say I have had wonderful conversations with neurosurgeons in my career. Even at 3 a.m., I've had conversations with caring clinicians who are not only outstanding medical experts, but who are clearly compassionate about the patients that we are co-managing. But for whatever reason, most emergency doctors I know dread calling neurosurgery. And to be fair, if I was forced to take hundreds of relatively pointless calls every single shift, I might get a little snippy as well. So let's talk about some research that might help. The AAST, or the American Association for the Surgery of Trauma, Brain Injury Guidelines, or just the BIG guidelines for short. And the point of these guidelines is to give us some clear criteria for patients who either need or don't need hospitalization, repeat head CT, and neurosurgical consultation. There are 3 categories. Big 1 is going to be low risk, Big 2 moderate risk, and Big 3 high risk, and you always get assigned to the highest category based on your clinical findings, or in other words, you need to satisfy 100% of the listed criteria to count as either Big 1 or Big 2. In terms of management, the high-risk Big 3 category gets everything. That's neurosurgical consultation, admission, and repeat head CT. Big 2, the moderate risk group, gets admitted, but they say they don't need a neurosurgical consultation and they don't even need a repeat head CT. And then the Big 1 group, the low-risk group, this would be a massive practice change for most of us. They don't need anything. They say observe them in the ED for 6 hours and then just send them home. Now, you're not going to memorize these, and it's hard to cover all these guidelines in detail on the podcast. Check out the show notes if you're interested in all the criteria, because, spoiler alert, these probably aren't ready for prime time, at least as they're written. But I think there's a few key features to focus on. Any abnormality on the neurologic exam is an automatic Big 3 or high risk. So to be considered low risk, you have to have a perfect neuro exam, and that makes sense to me. Intoxication is going to make you at least moderate risk. You can't be Big 1 or a candidate for discharge home if you're intoxicated. You need admission, but intoxication doesn't mandate a call to neurosurgery, and that also makes sense to me. Every patient with any anticoagulation and any form of an antiplatelet agent is high risk according to these guidelines. And so any antiplatelet, including aspirin, automatically mandates a call to neurosurgery. I'm not sure that makes sense, honestly. We can't do anything about the Plavix. We know that platelet transfusions are a bad idea. So what exactly is neurosurgery going to do? I don't know. But whatever, I do agree that these are high-risk patients and they need at least admission and a repeat CT scan, so I won't argue too much. Aside from those clinical features, the groups are basically divided up based on the size and type of bleed, and my guess is you should just look at the table if you're going to use these guidelines, but it's pretty obvious. Trace traumatic subarachnoid hemorrhage definitely doesn't need a call to a neurosurgeon. I know that, the neurosurgeon knows that, although unfortunately right now most of our medical system doesn't seem to know that, which is why I think these guidelines have great potential. All right, let's get to the evidence. Are these guidelines actually any good? So we have a recently published prospective observational trial looking at these guidelines. This is Joseph and colleagues 2022 in the Journal of Trauma and Acute Care Surgery. They included just over 2,000 patients from 10 trauma centers in the United States. 15 were classified as Big 1, low risk, 15 as medium risk or Big 2, and then the rest were Big 3. And the outcomes? So in the low risk Big 1 patients, there were 0 patients, no patients with neurologic deterioration, and no patients required neurosurgical intervention. So that's really good news. But unfortunately, this paper presents no stats at all. So we have no idea how high the 95% confidence interval might extend here. And given that this is, only 300 patients, it's probably relatively high. There were 1.3% of this group, the Big 1 group, that had worsening of their bleed on a repeat CT scan. For the Big 2 or the medium risk patients, only 0.7%, so pretty low, had a clinical deterioration. And although 7% of these patients did have progression of the bleed on a repeat CT scan, none of these patients required a neurosurgical intervention. And then the Big 3 patients were high risk as expected. 16% deteriorated clinically, 21% had progression on a repeat CT scan, and 20% ended up having neurosurgical intervention. Now, the real outcome of interest here was the need for neurosurgery, and there was 0 neurosurgery in either of the Big 1 or Big 2 groups, and that's a real win for these guidelines. However, I imagine the other numbers here might feel a little bit too high for most doctors right now. Big 2 had a 7% rate of progression on the repeat CT scan. I'm not sure that justifies the don't get a repeat CT scan that they claim. And then Big 1 had a 1.3% rate, and that's not accounting for the 95% confidence intervals. I'm not sure how many of us are going to feel comfortable sending patients home when there's a 1.3% progression on CT. So I don't know, the risk of worsening here might be too high to warrant skipping that repeat CT scan like they're trying to tell us. But, if nobody needed neurosurgery, I guess you could ask, who cares what the CT scan looks like? Now, to round out their data, they do tell us that if we had followed these big guidelines, it would have resulted in 425 fewer repeat CT scans, 401 fewer prolonged hospitalizations, and 511 fewer neurosurgical consultations in this cohort of 2,000 patients, so achieving their goals of less resource utilization. Now, there are some obvious issues with this study. First, there are a couple things that make me worry the complication rate might be higher than they're suggesting here. Not everybody got the same workup. Not everybody got repeat CT scans, so we might have missed some injuries here. And also, there were just way too many patients lost to follow-up or excluded because of missing data, and even 1 or 2 missed outcomes would dramatically change the results. And then, again, they present these numbers without stats. There are no 95% confidence intervals. But it's really the high end of that 95% confidence interval that we care about. A 0% neurosurgery rate sounds great, but it sounds a lot less great if the range of estimates is a 0 to 5% miss rate. On the other hand, there are some factors that suggest this might be an overestimate of risk, at least for the average community emergency department patient. These were trauma center patients, and it sounds like they're relatively sick trauma center patients. 20% of these patients were getting blood transfusions, so these aren't, your simple isolated head injuries. And so there's probably referral bias here. And so the average isolated head injury in our community emergency department is probably somewhat lower risk than the patients that got included here. My point is, the data here is great, but there is still a ton of uncertainty. Look, I love where these guidelines are going, but I don't think we need to be quite this aggressive right off the bat to still have a massive beneficial impact. Am I going to be sending home all of these big 1 patients right now? Absolutely not. But a 24-hour admission for observation and repeat exam without neurosurgery consultation and without repeat head CT scan is still going to be a big decrease in resource utilization and is almost certainly justified by the findings of this study. And for the big 2 patients, I agree with these guidelines. They don't need an immediate call to neurosurgery. You can save that for if they deteriorate clinically or if their CT scan gets worse. But with a 7% rate of progression on CT, I think a repeat CT scan might still be warranted if we're going to be admitting these patients anyway. I think those 2 steps would be fantastic, and they would start the process of decreasing resource utilization while keeping our patients safe considering the limitations in this data so far. I guess the real question is, can we get buy-in from our admitting teams? Because I think emergency doctors will accept this in a heartbeat, but to some extent, this decision is out of our hands.
Hi, it's Tagg from Don't Forget the Bubbles with another Pediatric Pearl. You walk into the cubicle. It's 8:20 on a Thursday morning, and triage has sent you a note. 2-week-old male, bleeding from penis, post-circumcision. Baby is calm, a little pale. His nappy is streaked with blood, not soaked through, but enough to make you pause. Start with a focused history. Has the bleeding been continuous, or did it stop and then restart? Is the baby feeding well, passing urine? Is he alert? And then use saline to clean the area and inspect it carefully. Most of the time you find the source of bleeding in the region of the frenulum. It's a small capillary ooze. Very rarely is it arterial, very rarely is it dangerous, but it's definitely dramatic. And here's the context that helps. Most circumcisions heal without problems, but bleeding is the most common early complication, happening in about 0.1 to 2% of cases. Just enough to be important, rare enough to feel unfamiliar. So what do? Step 1, like all bleeding. Direct pressure. Take some clean gauze, roll it up, hold it over the site. Apply steady, confident pressure for 5 to 10 full minutes. No peeking, just hold. If it stops, you're done. If not, look again, and if you see a pinpoint ooze, reach for the silver nitrate. Still bleeding? Well, try some topical adrenaline on gauze, or if your department stocks it, you can use Surgicel or TXA soaked gauze. These are gentle things to do. But when should you escalate? You escalate when you suspect bleeding from the frenular artery. The bleeding continues despite local measures, and Bale is pale, lethargic, feeding poorly, or not passing urine. And if so, get surgical help early, urology or general surgery, depending on your setup. Bleeding that happens early, within 48 hours, is usually due to friction, poor hemostasis, or slip dressing. Late bleeding, 5 to 10 days later, may suggest infection or a clotting issue.
All right, so key take-home point here is if local measures like 5 to 10 minutes of constant heart pressure with epinephrine and or TXA soaked gauze plus minus silver nitrate don't stop the bleeding, suspect an arterial bleed and get the patient to a surgeon ASAP. These kids can bleed out if source control isn't secured early. All right, up next, we have Hans Rosenberg, who's going to talk about something we see not too infrequently, and that is CT contrast allergy.
And now a word from one of our sponsors, Paratus, the all-new emergency assistant. Paratus combines everything you loved about Easy Resus with powerful upgrades, just-in-time procedural guidance, stress-proof organization, and Atoms, the intelligent assistant that helps you find exactly what you need. Whether you're in the ER, on transport, or in the field, Paratus keeps you ready for anything. Learn more and start your free trial today at paratusmedical.com/emcases. That's PARATUS medical.com/emcases.
Welcome to another CGEM and EM Cases collaboration. Today, we're going to be chatting with Dr. Ariel Hendin about her latest Just the Facts article, Contrast Allergy in the Emergency Department. Can you tell me what is the risk of having an adverse reaction to contrast in the general population?
So adverse reactions to contrast media, specifically for CT, are overall quite rare, about 2.5% for all types of reactions. And it's important to note that that 2.5% comprises a wide spectrum of potential reactions. Not all of these are true allergic reactions. In about 0.4% of the population, so a very low rate, true hypersensitivity reactions, which are going to occur within about an hour of receiving contrast. And these, again, are a spectrum from maybe some urticaria to true anaphylaxis. And true anaphylaxis is very rare, about 0.02% of patients who receive contrast. And then lastly, and a little bit tricky for us, but again, usually minor, we can see delayed hypersensitivity reactions. So these are primarily T-cell mediated skin reactions that occur within days after receiving contrast. So we may not even be aware of them in the emergency department. And these, again, by and large, are going to be quite minor with maculopapular exanthema, but it can range all the way to severe cutaneous reactions like Stevens-Johnson syndrome. And all of these delayed skin reactions are only in about 0.05% of patients who receive contrast.
So to summarize all that, we can really say that the reactions that we truly care about are very, very rare in the less than 1% range, if not somewhere around there.
Exactly. And in the more recent data, these numbers being reported are much lower than they used to be with the older contrast molecules.
Excellent. Now, how do I assess someone in the emergency department to determine that they can receive IV contrast safely if they have an IV contrast allergy listed in their profile?
So it's so important to clarify what that means, because very often we'll see a label of contrast allergy, and the assumption is often, oh, the patient can't receive contrast. But if there's a good reason to give contrast, then you have to dig a little bit deeper. Ideally, what you'll be able to find out from the patient's chart, although not always, is what type of contrast they received and when, because that'll make a big difference in terms of whether you can safely give contrast. And you also want to get more information from the patient about what type of reaction it was, if they recall or if it was documented. There's a few things that are important to know on history that can help you immediately rule out any kind of contrast allergy. So for example, if the patient once told a provider that they were allergic to contrast because they were allergic to shellfish, which has a high amount of iodine, or if they're allergic to iodine, these are not contrast allergies. The contrast molecules are iodinated, but that has nothing to do with a hypersensitivity reaction. So you can be confident that that's not an actual allergy. Then once you've kind of cleared those, in theory, easier questions, what you want to know is dig into really what the nature of the reaction was. So the hypersensitivity reactions can be divided into mild or moderate. Things like I mentioned, like a mild urticarial reaction, mild wheezing or some throat tightness, all the way to true anaphylaxis that we would recognize as such with stridor, bronchospasm, hypotension, things like that. And ideally, you'll be able to clarify whether the reaction was mild or moderate or severe. And also if the patient recalls having any treatment at the time.
All right, let's start with that then. We have a patient who reports a mild to moderate IV contrast allergy. What would be their management in the emergency department?
So a little bit of it depends on the year in which they received their contrast. Because like I mentioned, the reactions to the contrast molecules used pre-2000 were much higher in terms of rates. So if they had a mild or moderate reaction pre-2000, the molecules used today are different and they can safely receive contrast without further concern. If they had a mild to moderate reaction after 2000, which is probably more likely in 2025, then ideally you'll know which type of contrast agent they received, and you can simply ask the techs to switch the contrast agent, which can decrease the rate of reaction by up to 60%. If you don't, however, know which contrast agent was given, for example, they received it at a different hospital or it wasn't documented, then you can still proceed with the CT. You may want to pre-treat with second-generation antihistamines, things like cetirizine or loratadine rather than diphenhydramine. These are thought to reduce the risk of breakthrough symptoms by a small amount. Importantly, and this is new as of January 2025, in a guideline co-authored by the Canadian Association of Radiologists and the Canadian Society of Allergy and Immunology, there is a recognition that the data for pre-treating with steroids is actually not strong. And so for mild to moderate reactions, and in fact for severe reactions as well, there is no strong data suggesting that pre-treating with steroids, those protocols that we have been doing for years with hours of steroids in the department before the patient can receive their CT, is not necessary. Hopefully, with knowledge translation, we will no longer be treating with steroids for hours before our patients can get their imaging.
Yeah, maybe they'll listen to a podcast or something. Great. Now, the last one, which is probably the one that most of us worry about, what if they report a severe IV contrast allergy, for example, anaphylaxis that required epinephrine and some monitoring afterwards?
Yeah, so even though I've said that the rate of anaphylaxis to IV contrast is low overall, we've all responded to calls in the CT scanner, and we don't want to be responding to a very sick patient in the scanner. And so for patients who have true documented anaphylaxis, you need to really carefully consider whether there aren't any other imaging modalities that you could use instead of CT to get to the answer that you're looking for. For example, can you get an MRI? If you have access to it, can you use ultrasound? Things like that. If you can't, and the CT is urgent and contrast is very important to the question that you're asking, then you can pre-treat with antihistamines only, still not steroids, and proceed with the CT, but ideally with switching the contrast if you know. And then, of course, if you proceed with CT because you need to get the answer and it's urgent and the patient has anaphylaxis, then you would treat as you would any patient with anaphylaxis with epinephrine after having stopped the contrast injection, obviously. One of the blood tests that the allergists find helpful that we essentially never order or have use for in the emergency department, to be honest, is a tryptase, because this can help them distinguish between a true hypersensitivity reaction if it's elevated versus a physiologic reaction, which could still be severe.
Okay, so from what I understand, we would try to use a different modality if we can. We can try to use a different contrast media if we can. There's no significant role for pre-medication of those patients if, say, it's an emergent indication, for example, something like a dissection or something like that.
Exactly. You'd still give antihistamines, but no indication for steroids.
Great. Thank you very much for this. I think this really has the possibility of changing practice pretty much every day in our emergency departments. Thank you very much, Ariel.
Great. Thanks very much, Hans.
Let's take a little break to hear from one of our sponsors, Metricaid, the experts in complex physician scheduling since 2012. Metricaid's expert schedulers are their secret sauce. These people truly understand the complexities of physician scheduling. They empower us by providing the tools we need to manage our teams efficiently. At the same time, they give physicians more freedom to share their workflow preferences, so schedules aren't just fair, they're actually workable. Metricaid's system is built to make your schedule work for you. They take the stress out of shift planning so that you can focus on what matters most. Go to metricaid.com/emcases to learn more about how smarter scheduling can work for you. That's metricaid, one word, .com/EMCASES. All right, next up we have sim educator Shawn Seregren, who's going to explain how adopting a calm but firm tone in resuscitations
can sharpen your team's performance.
Have you ever noticed how the whole feel of a resuscitation can shift just based on one person's energy? The room might start steady, but if the leader is rushed and anxious or sharp in their tone, everyone else is too. On the other hand, if the leader's voice is calm but firm, the room will often steady, even when the patient's crashing. There's a name for this. It's called emotional contagion. It's the way that tone and energy spread unconsciously to everyone in the room. In a resus, the leader is often the loudest signal. More than anyone else, the team mirrors the leader. Their voice, their pace, and their composure set the emotional climate of the room. That's the shared atmosphere that the whole team is working in. I've seen this again and again in sim and real resuscitations. A leader will come in sharp and impatient, and then the room just gets really tense. They get scattered and they get frantic. But when a leader slows down and lowers their voice, keeping the tone steady, they can feel the room exhale. Everyone just exhales. The same sick patient, the same chaos, but it's a completely different climate. The challenge is that emotional contagion will creep up on us. Most leaders don't actually realize how they sound until the team is already reflecting it back. And there's also another side of it. Sometimes the leader never really notices it at all, but the team can help. A calm voice from the nurse at the bedside or a steady, matter-of-fact update from the recorder, all of that can just bring the tone back down. Just like anxiety spreads, calm can spread too. And sometimes the quickest way to steady the leader is for someone else in the room to model that calm. So how do you catch this yourself? Sometimes it's as simple as just pausing before you speak. Even half a second of silence changes how your voice comes out. One deep breath before the next order, it will reset your cadence. Lower your voice. Don't raise it. Calm does not mean quiet. It means steady and it means firm. And summaries, they're not just about information. Each recap, like here's what we've done, here's where we are, and here's what's next, that's a chance to reset the tone of the room. None of this is easy. It does take practice. In sim, I've seen leaders only start to notice it after several cases, but when they do, the difference is immediate. The room sinks and the climate shifts. That is emotional contagion. The team feels what the leader feels, and because the leader is the loudest signal in the room, the tone and composure matter just as much as any procedure or any intervention. Because in the end, the patient really doesn't just need meds and interventions. What they need is a team that's steady. And that starts with the leader.
All right, that brings us to the summary of this Quick Hits podcast. But before we get there, I'm pleased to announce the date for the next EM Cases Summit. After the last summit in November 2024, many of you asked when the next summit was going to be, and it's going to be November 19th, 20th, and 21st, 2026. It's the largest and best online virtual EM conference in the world, featuring EM Cases guests you've heard on the podcast. And we've got some new surprises for you this year too. So mark your calendars, November 19th, 20th, 21st, and 26th. You can tune in from anywhere in the world. So let's summarize the key take-home points from today's episode. For traumatic pneumothorax and hemothorax, start by categorizing the patient. When patients with chest trauma roll in, think in 3 buckets: peri-arrest or hemodynamically unstable, and precariously stable, and fully stable. That categorization drives everything: your imaging, your urgency, and whether you should be reaching for a scalpel immediately. In peri-arrest patients, there's often no time for imaging, and bilateral finger thoracostomies may be life-saving. Next, ultrasound beats auscultation, and chest x-ray can lie to you. Absent lung sliding on ultrasound in a hypoxic or hypotensive patient is enough to act on. You don't need to wait for a perfect x-ray. Supine x-rays miss a lot of pneumothoraces, so if you do use them, look for indirect signs like the deep sulcus sign. Tracheal deviation is late, unreliable, and not worth waiting for. And for pneumothorax, stable patients deserve CT, and size matters. Pneumothoraces greater than about 35 millimeters on CT or 38 millimeters on chest x-ray generally warrant chest tube placement in the right clinical context. For hemothorax, CT is essential. Think roughly 300 mils or a pleural thickness over 1.5 centimeters as a practical threshold, but always anchor decisions to the patient, not just the measurement.
Justin Morgenstern reviewed the latest brain injury guidelines and told us that not all head bleeds need neurosurgery consultation in the ED, but context is everything. The guidelines stratified intracranial hemorrhage into low, moderate, and high-risk groups with the goal of reducing unnecessary neurosurgical consults, admissions, and repeat CTs. Low and moderate risk patients had 0 neurological interventions in the available evidence, though some did show radiographic progression. The takeaway isn't to blindly discharge patients, it's that many of these patients can be safely managed without reflex neurosurgery calls, especially with good clinical reassessment. For our CGEM Just the Facts this month, we learned that true contrast allergy is pretty rare and steroids are pretty much out. True anaphylaxis to modern IV contrast is exceedingly uncommon, and many so-called contrast allergies aren't allergies at all. Shellfish and iodine allergies do not count, and mild prior reactions often allow safe re-imaging with a different contrast agent. Recent Canadian guidelines emphasize that routine steroid pre-medication isn't supported by strong evidence. Antihistamines alone are usually sufficient, even for patients with prior reactions. And finally, a reminder about resuscitation leading an emotional contagion. In resuscitations, your tone sets the tone of the room and the team and the resuscitation. Calm, steady leadership spreads just as efficiently as anxiety, pausing before speaking, lowering your voice, summarizing the plan. That can reset the entire room. In the end, patients don't just need procedures and medications, they need a team that's steady, and that starts with you. All right, until next time, take it easy.